heart attacks can present a number of different ways. Perhaps the number one symptom has to do with chest pain. At least we say it's chest pain, but it may not be chest pain. It may be chest discomfort. I say that because people will argue with you that if it's not chest pain, they won't come in. So let's say there's chest discomfort, something occurring within the chest. Now there's typical and there's atypical symptoms. Now the typical symptoms, the pain or the discomfort, whether the discomfort is an ache, a burning sensation, or pressure, occurs in the middle of the chest. It may be a pressure, a burning, or an ache, but the patient cannot locate it with a finger or so. It's deep and usually more diffuse. Many times they take their hand across their chest. When they do that, especially if they were then pull their hands together in a gripping fashion, that's a telltale sign. That's called Levine's sign. And once the person gives you that, that's an automatic admission just about, because once they have that gripping, squeezing type sensation, we kind of know what they're trying to get across. But many times before that, it's a diffuse type discomfort across the chest. And it can leave the chest. It can go into the arms, especially the left arm. When it does so, it goes to the inner aspect majority of the time. Once in a while it can go to the right arm, majority of the time to the left arm. But the inner aspect does not go down the entire arm, just the inner aspect. It may go into the jaw or to the tooth. Now initially when it comes on, it may not be prolonged. It may be, we call stuttering, which means it goes away, comes back. And it may do that off and on for a period of time. And that may be hours to days to even at times a week or so. What's important to recognize is that if they occur in that manner, that it's important at that stage to get it checked out. Now many times when it occurs stuttering, what happens is it undergoes what we call a crescendo, a bolero. It seems to come more often, it lasts longer, the intervals are shorter in between, and then the pain gets somewhat more severe. It's getting worse. You can almost feel it blocking off. And then it gets to the point where something happens and it becomes prolonged. What has happened at that time is complete occlusion has taken place, and now you got 6 hours to intervene, and 1 hour if you're going to maximize your therapy. And that's where we have problems, because it's almost impossible to get into the hospital within an hour to dissolve that clot and the like. And you can see that if it has this period leading up to that, that the time to get involved is in that period leading up to that, because that's the time where you got more time, and if you intervene, you can actually prevent the death and damage of the heart muscle from taking place. Now, they're the typical symptoms. Now, you can have atypical symptoms. You can have it occurring in a jaw, or maybe in an elbow, different parts of the body, and it's uncomfortable. It may be described as pain. What gives it away, or at least points in the direction of the heart, is that it also comes with activity and relieved by rest, and has this crescendo bolero type characteristic as well. And then that gives it away. Anything that keeps coming back and becomes more prolonged and has shorter intervals, and it's uncomfortable, and it's in an elbow or a jaw or a tooth, get it checked out. Now, that's the typical and the atypical. Now, there are many kinds of chest discomfort that is not related to the heart, but may confuse you at times. And usually this is many times a chest discomfort in which a person will take their finger and say it's here or it's here. History-wise, we know when that occurs, the likelihood of that being heart is very low, because usually heart discomfort or lack of oxygen, we call ischemia, is usually not present that way. It's not where you can locate it, and it's at one spot or so. When that occurs, then you look for some tenderness and see if you can reproduce the pain, and then we call that chest wall discomfort. So if it's well localizable and you can pinpoint it, and especially if it's tender, it usually points away from the heart. Now, if you got some discomfort of the chest and it seems to come with breathing or with exertion, we call that pleurisy, and that may be due to inflammation either within the chest or around the chest or around the heart. And usually that also is not indicative of, say, a heart attack. But again, we place a lot of our initial evaluation on proper history taking. It's what determines whether or not we keep the patient long enough to make a decision. If we can be absolutely sure that it's chest wall discomfort, we can send a patient out earlier. If the patient has the characteristic central chest discomfort, pressure, aching, and becomes severe with or without EKG changes, we admit these patients to the coronary care unit. If the discomfort is in the chest and doesn't obey any of these two principles and doesn't come and go, then we observe the patient. And after about 12 hours, if we don't have enough evidence by serial EKGs or enzymes, then what we usually do is do a stress test and find out if this patient with low probability has ischemic disease. If they pass the stress test and they get their heart rate up to 150 to 160, there's no chest pain elicited, there's no EKG changes, we can comfortably send that patient home and not necessarily have to admit them for 2-3 days, which was done before. So there's a way out that we can accomplish as we invite people with possible early symptoms to come in, is not have to necessarily admit all these patients to the hospital. So we wait and depend heavily on that history taking, not just the initial history taken, but we repeatedly go back and take more and more history as time goes on, because things will change. For example, if a patient is on nitroglycerin and nitroglycerin takes away the discomfort within 5 minutes, that points to the heart. Whereas if they take a nitroglycerin and it takes 20 or 30 minutes to go away, we know that's not the heart, because it usually is something else, unless they're in the midst of a definite heart attack, in which the EKG will show it anyway. But we use the response to nitroglycerin to tell us whether or not it points in favor of the heart. So many little things we do: repeated history taking, wait for the blood test to come back, take an EKG with chest discomfort, and then we have a consensus of after about 12 hours, and then make a decision whether or not it's low probability, send home after an EKG, after a stress test, or perhaps not enough evidence, admit the patient, and then work out the problem upstairs. When heart attacks begin, they don't get respect, either by the individual or people in their presence. And a good example of that are the people that drive up to the emergency room and see that emergency room sign and actually walk away or drive away because they don't perceive as what they're having is an emergency, severe. And what they got to realize is potentially severe, because it could take your life. And it doesn't have to be severe and crushing when it presents and the like. And there's good examples of that. And each one of us has had people in our midst, been involved with people who have had periods of opportunity where we could have intervened and actually prevented people from dying. One good example is when I was a pharmacist practicing pharmacy, and a pharmacist do periodically prescribe over-the-counter medications for patients and the like. And one day I was out taking care of people in the store when the local tailor came in, and he started telling me about symptoms, stuttering symptoms that would occur off and on. And I knew it was somewhat serious or meaningful at that time, and I tried to tell him to get to the hospital or get to the doctor. And the store got busy, and Jack the tailor went on his way. Well, to make a long story short, 3 hours later he was found dead. He had went back to the tailor shop, had laid down, and never woke again. And as I look back upon that, I can reflect, but I can tell you that when I talk to groups, and there's not a person in the audience who hasn't come into contact with someone in their midst who had some symptoms and didn't intervene and didn't do something about it. And what I'm trying to say is that not only do you have to recognize it, but you have to be emphatic enough. You have to get involved. You got to be a good Samaritan. You've got to be a buddy system. And in fact, that's how we're going to win this war at home, is with an army of early heart attack caregivers, people who stop and take the time and recognize that that particular person who's having these symptoms, it may be very important, and now's the time to get involved and not to become an enabler and say, oh, that's mild, that's indigestion, I'll see you later, Jack or Sue or something like that. But take the time to get involved, because only by having people in the midst, caregivers for heart attack, especially when it's early, will we win this war at home. This war is winnable. This war is winnable, not just with the individuals being in contact with themselves, but with an army of early heart attack caregivers, people who know the message and know to intervene here is very important and meaningful, and can mean a difference between not just life and death, but the kind of life that the person is going to have. Because if you damage half your muscle, you know, you may live, but you become less of a person. It's important to appreciate the true value of a heart. I mean, the heart's meant to last 100 years. And if you had to buy a heart off the shelf, a used heart, it would cost $100,000. That's what a transplanted heart costs. And we try to get people to realize and appreciate that if a used heart costs that much money, what would a new heart cost? And if you had that much possession or valuableness to that, you would take good care of it. You wouldn't smoke and pour tar on it, or if it had a noise in it, you would go and get it checked out. It's more powerful engine than even a Mercedes motor. So if you have your car, a good car parked in front of your house, you take good care of it. If we could take the heart out of the chest and park it in front of your house, people would value that, or truly appreciate the value of it, and take every effort to take care of it, not only to prevent problems from taking place, but when it's having a problem, like a small noise in the engine, is to come in early and prevent a major problem from taking place. And that's what we're saying about early heart attack care, is actually trying to intervene early when symptoms are mild, when you can prevent death and damage from taking place. It's a war that's winnable. It's winnable. Okay, in 1981, we opened the nation's first chest pain emergency room. And we did so because we were a community hospital trying to get to the heart of the problem. And we've always recognized the heart of the problem was in the community. At that time, sudden death was a major problem, and we were trying to get to sudden death within the community. At that time, we looked at different strategies. Dr. Panchich in Belfast was taking an ambulance to the scene of the patient with a heart attack. There were similar ambulance programs here in the United States. We looked at that and did not find it feasible. We thought it was be too costly. And we said, well, rather than run to the scene of the accident or the heart attack, it might be better to go out and educate the community that when you're having chest pain, that you could be in the midst of a heart attack, and that the reason for the cardiac arrest, namely ventricular fibrillation, which is an arrhythmia disturbance, occurs shortly after you've had that chest discomfort. So why not get out and educate the populace that this arrhythmia, this lethal arrhythmia occurs shortly after you've been having the chest discomfort, and then prepare something within the hospital for people coming in early. And that's how we got started with the nation's first chest pain emergency room. Its purpose was to have twofold, and it's always been twofold: education and preparing the hospital for the patients coming in with symptoms to treat, to prevent the cardiac arrest. And part of that program was an educational program that we did, and we accomplished in many different ways. We had speakers bureaus. We worked with the local high schools. We taught the graduating high school students that what caused cardiac death was an arrhythmia related to the chest pain, and that it was important when someone was having chest pain to get into the hospital within a short period of time. That's how we got started. And over the years, we've had an increase of admissions from 1,000 to about 1,800 because people in the community know that this is a chest pain center and that we act rapidly when someone comes in with chest pain. Initially with a drug called Xylocaine to prevent the need for cardiac arrest. But then we found out we had drugs to dissolve clots that were causing the heart attack. And then we got involved with a number of different programs on a national basis to study what they call thrombolytic therapy, drugs that dissolve clots. At the present time, only 25% of patients with heart attacks get thrombolytic therapy, and only 10% get it within the first hour. Therefore, only about 2 to 3% of patients are getting effective thrombolytic therapy. So if you focus on thrombolytic therapy, which you're really focusing on the clot, which is blocking the vessel, we're not doing an excellent job, mostly because of the fact that it may be almost impossible to get to see all these patients within the first hour, and half the patients don't even have the EKG changes to tell you they're in the midst of a heart attack. So with that in mind, we've been looking at this, and it just seems to us incredibly not intelligent for us to wait until the vessel completely blocks off before getting involved. When if you go back into the literature, 50% of patients have warning signs. They use the term prodromata, or prodromal symptoms. And it's just very similar like the prodromal symptoms of a cold. If you take something early, you can nip it in the bud. And that's exactly what we'd like to do about heart attack, is be involved early so we can do something and nip it in the bud. And if we can do that on 50% of the patients who have heart attacks, we could reduce the number of heart deaths from 600,000 to 300,000, and that would reduce it to a number 2 status within a short period of time. So with that in mind, we've changed our strategy, and the chest pain centers now have become messengers in terms of getting out to the communities the fact that heart attacks have beginnings, and that if you have the telltale symptoms of stuttering type chest discomfort off and on, even though it's mild, it's okay to come in. And the chest pain centers become a user-friendly avenue for patients coming in with mild symptoms. So it's an entire movement across the country, an educational movement started by hospitals through the chest pain ER, moving into the community, letting people know that that heart attacks have beginnings and that it's okay to come in when symptoms are mild, and that the chest pain center serves as a user-friendly place for these symptoms to be checked out. It's an unused strategy. Right now we're focused on the vessel completely blocking off and trying to dissolve it and trying to get to the patient within the shortest period of time. But I think the sound barrier will be broken when we move beyond the complete clot to where the clot has not yet completely blocked off the vessel, and it has that ball valve sort of effect whereby symptoms are coming and going, and that if you intervene at that stage, intervention actually is prevention, because you're preventing death and damage from taking place. And that's exciting. And why hospitals are coming on board is because déjà vu, because it happened before and it can happen again. If you ask the American Heart Association and NIH who discovered coronary care unit, they'll tell you it was a general practitioner in Bethany, Kansas, who put together the first CCU, and within 7 years, every hospital in the United States had a coronary care system. And the reason that took place is because it was a power of an idea whose time had come. There's nothing more powerful, not even armies are more powerful than an idea whose time had come. And exponential growth took place overnight. And we have seen the benefits of coronary care units. They have become the research benches for our tremendous progress over the last 25, 30 years. What we need is a similar type of progress and a learning curve in the community. And that's what the chest pain centers represent. Focus on chest pain as a risk factor, alerting the nation that heart attacks have beginnings, and it's okay to come in when symptoms are mild, and developing these chest pain centers across the country. Within 2 years, we've had close to 300 hospitals come on board with chest pain centers in 43 states. They're not coming on board because we're twisting their arms, they're the CEOs and things like that. They're coming on board because it makes sense. As one executive told me, it's the right thing to do. It's the proper thing to do. Even if it costs some money initially in setting it up. And really it doesn't cost that much money because most hospitals have been able to take with what they got and do things a little differently. Not necessarily build a brand new structure and put a lot of money into it, but it's a mindset more than anything else. Changing the mentality and trying to get people with early symptoms to come in. True, a lot of these patients may not have ischemic disease, and we may have to find new ways of ruling out coronary disease, perhaps in the emergency room before sending them home. And one such study, Dr. Giller has been able to put together stress testing after 12 hours in the emergency room, and these low probability patients, sending them home rather than admitting them to the hospital. So what we need are to invite all comers with chest discomfort that's identifiable enough to be perhaps an early sign that they're having a heart attack, and then to deal with these individuals and not run from this strategy. Because if not, then we're going to have 600,000 deaths each year by the end of the century. What this is a strategy based on the fact that heart attacks do have beginnings and that we've got to intervene. And the heart of the problem is in the community, and we've got to invite the community in with early symptoms and do something about them. Hey, hi. You had some chest discomfort?
Yes.
This time?
Yes,
I did. The last time you had chest discomfort, was this similar type of chest pain in the leg?
Yes, the pain was exactly the same.
Uh-huh. Okay. Can you describe that pain last time you had?
It's a fullness right in the center, and it spread to my back and my right shoulder.
Okay, last time you had it, how long did you have it?
Approximately half an hour.
Half an hour. Were you home with her at that time, Mrs. Green?
Yes.
Did she complain to you at that time?
When the first time.
The first time.
Yes. When the pain got,
How did she look to you at that time?
she looked weak,
Mm-hmm.
and I didn't know whether she could even stand.
Mm-hmm. Was she sweating or short of breath or just discomfort?
She was within discomfort.
Mostly discomfort and things like
Yeah.
that. So you spent how long at home at that time?
I guess it was about 20 minutes after I started to feel bad.
Mm-hmm. And then what made you decide to come in at that time?
She wasn't getting any better. She was getting worse.
So you continued with the discomfort and it didn't go away.
And the first time I actually passed out.
You passed out too,
Yes.
at home?
Yes, at home.
Okay. Did the ambulance, paramedics come?
Yes, they did.
Okay, fine. Did you wake up by that time?
Yes.
Okay. So paramedics brought you immediately to the hospital. Were you
No, they didn't.
No?
They did not.
What happened at that
They
time?
dismissed it. They said they couldn't explain what it was, but I was okay. I woke up and everything was fine.
And were you having discomfort when the paramedics came there at the time?
I passed out. I was actually out, cold, when they arrived.
But they took a history then that you were having discomfort in the
No, he did not. He asked what was wrong.
uh-huh.
I described it the best I could. And after I described it, he walked around and he said, well, maybe she seems to be paranoid because he said, I don't see anything really wrong.
Did you talk to him because you were too ill or you were just waking up?
I was just waking up.
You were waking up?
Yes.
Uh-huh. But the discomfort, did it come back at that time?
Yes, yes.
But
It
they
was
didn't
very
think...
much still there. And I was weak, and the sweating was still there, and the nausea was still there.
Were the two paramedics And
Two.
both of them concurred that you looked well enough that you were not having a real problem.
Right.
That you knew enough, and then you got your son, and he brought you directly to the hospital. And
Yeah, after they wasn't doing anything.
mhm.
I found out they wasn't going to do anything, and something had to be done.
So you took the bull by the horns and
Right.
came here directly. Very good. Now that was last time, and you were helped because you had the drug that dissolved the clot. We found out that your vessels were not that bad, that a lot of your problem was clot formation.
Right.
And I've been following you since that time, and you've been doing fairly well.
Fairly well,
Mm-hmm.
up
Back-
until now.
Back to work, a little stress
Full-time.
with the jobs and things like that, but that's you know, I know you've been with your job, you've been under some degree of distress
Right.
or something like that, but no more than most people, I would think. And you've reduced your risk factors. You no longer smoke, is
No.
that right? Uh-huh.
Not at all.
So you've been trying to stay in good health?
Exercise.
Mm-hmm. Now tell me about this episode now. What time did this new episode start?
This new episode started about 12:30 at night. I was sleeping, and it woke me
Mhm.
from my sleep.
So it's been about 3 years,
Yes.
and you've had no discomfort at all,
Nothing
and
at all.
abruptly, 12:30 at night, you had this discomfort.
Right.
And what did you do this time?
I immediately got up and took nitroglycerin, and this is the first time I've ever had to use it in the 3 years.
Mm-hmm.
Nothing happened. The pain was the same.
Mm-hmm.
I took another one, and it still didn't go away. At that point, I woke my mother, and we came immediately to the hospital.
Who made the decision? Did you make the decision, or did she make
I
it?
did.
Huh? Huh?
I did.
Were you
I
trying to find reason not to come?
No, no.
So you were
Well, she
willing this
was
time to
agreeable.
come.
She agreed.
She agreed this time.
Yes.
Uh-huh. And why did you agree this time to come on?
Because I knew how important it is to
Good.
come early.
Good. You want to tell me more about that?
Well, after the first heart attack, I watched the video that you made about early symptoms and what to look for, and if you have problems, what to do. And I remembered that you take your nitroglycerin, and if it doesn't change, immediately seek help. So
Mhm.
that's what I did.
Very good. Did you have much other discomfort, other symptoms at this time, or just mostly the pain and
The pain and the sweating.
right, so you got here within a half an hour, I think, this time. Very
Yeah.
good. Mm-hmm.
They had given me some other things when I first arrived, but nothing seemed to help.
Mm-hmm.
And when you gave the order for the clot dissolving medicine, almost immediately the pain started to subside.
Very good. So you think you were helped this time because you came in early, because you knew that it was important to come in early, and the first time around, even though you had a lot of discomfort and even passed out, you were not believed.
Not at all.
Uh-huh.
Well, see, she was a woman. If she had been a man right away, it wouldn't have been no problem. Only men get heart attacks. Women do not have heart attacks. Everything you hear about heart attacks is men. Women also have them. I do know that. God knows I'm living proof of it.
But you actually have come to that belief that the world doesn't believe that women have heart attacks.
No,
Is it-
but if
what
she'd have been a man, if it had been my grandson, yeah, they would have took his word for it.
have you seen this before, or and
I've seen it before.
uh-huh.
I've actually had two friends who have gone to the emergency room with problems, and they didn't know exactly what it was, but they were diagnosed as having a heartburn or indigestion, sent home, and one of them actually died.
So you knew some of that ahead of time, and you acted on that information. And you think you two are a good combination together? Or you think two better than one? You help each other out in your thinking?
As
When it
far
comes
as
to that, yes.
In terms of the first time around,
Yes.
it sounds like Mom was you were just recovering. I mean, you were just
Yes,
waking up, things
yes.
like. But the second time around, you were
I knew
You're-
exactly what was going on.
And you knew that you wanted to come early.
Right.
And maybe you got a little help from her, but you were,
Right.
you were.
We were both
you're-
ready at the
you're very
same
right,
time.
Yeah, I think so. Very good. Well, there's no question that this time around,